Welcome to this second carer clinic with Dr. Raja. I'm Sue. I'm Head of Services at Dementia Carers Count, and I'm joined today by Dr. Raja again. Some of you might remember that Dr. Raja joined us a couple of weeks ago to discuss the symptoms of dementia. Raja is a practising elderly and dementia care specialist, and now I've probably done most of your introduction for you. Would you like to add to it at all, Raja? Sorry about that.
No. It's good. It's good to know from a clinical perspective, but I also want to say that I do have members in my family who have experienced dementia, so I have seen it from the other side too.
Okay, thank you. So we're going to pick up today, aren't we, Dr. Raja, where we left off last time, where we were talking about the signs and symptoms of that somebody might see if someone has dementia, and then we're going to look a little bit more about memory clinics and how they work. So just to say for viewers, if you have any questions or comments, please do put them in the chat box and we'll try to address them all. Sometimes it takes us a little while to spot them and to put them in the right place according to what we want to discuss today. And if we don't get to your comment or your question, then we will take some time afterwards and one of us will get back to you, or somebody from the team will get back to you. If you would prefer to private message us, if you want to keep it anonymous, by all means do so as well, and we'll get to those questions as well. So Raja, as we said, this is the second in the series of three live sessions. The first one we looked at some of the signs and symptoms, and today we're going to look more at what might happen at a memory clinic and what are people looking for at a memory clinic. Before we do that, could you just do a recap? I know you introduced the FORGET acronym last time. Could you just do a quick recap for us of
Yes,
what
absolutely.
FORGET is?
So last time we talked about what are the common symptoms of dementia and how to recognize them. And I discussed about this easy way of trying to look at symptoms of dementia using the acronym FORGET, because forgetfulness is the most common symptom of dementia. So if we look at the acronym FORGET, then F is for failure to recognize familiar faces. So that could be family members or friends. O is for odd behavior, odd thoughts. So that could be like simple things like someone is getting into my house and stealing things when they've just misplaced objects. R is for repetitive or reduced speech. G is for having grooming problems, so looking after oneself. E is for evening restlessness, including poor sleep or changing sleep pattern. And T is troubles with toileting behavior. And I said that these symptoms should be present for at least 6 months continuously for us to start looking at whether this means a dementia or not. And hopefully we're going to build on these symptoms and see how a diagnosis of dementia is arrived at using clinical interviews, investigations, and looking at the types of dementias.
Brilliant. Thank you, Raja. And like you say, what we're going to do is build on that FORGET that we covered in the last live session. Just for viewers, we will put that FORGET acronym in the chat again. And if you want to watch again or see for the first time that last Facebook Live, then that's on our YouTube channel as well, and we can put the links in for that. So I think what you've said, Raja, is that we're going to expand on some of that FORGET now and think about some of the things that might present in clinic, but also that all of that list that you said, the FORGET, those sorts of symptoms can come at different orders, can't they, for different people, for many, many reasons. And one of those reasons being that there are many, many different types of dementia.
Yeah, absolutely. And that's why I think it's important to focus on some of the common types of dementias that people might encounter. And the most common thing that people do tend to talk about is Alzheimer's disease-related dementia, which has also become the kind of common term for dementia as such. But it's important to understand that Alzheimer's dementia is one type of dementia, albeit it's the most common type of dementia. And that's where forgetfulness fits in, because the most common symptom that someone with Alzheimer's dementia will present will be forgetfulness, which will then go on to becoming them a bit confused, disoriented time or disoriented place, before all other aspects of cognition may fail over a period of time. So Alzheimer's type of dementia, most common symptom will be forgetfulness over a period of time, and it will kind of gradually progress. If I was to contrast it with something else, then the second common type of dementia is a vascular form of dementia, which is interesting in the fact that it's not actually a brain problem if one thinks about it. The blood supply to the brain is compromised for whatever reason it is. And when the blood supply is compromised, then brain struggles to function as any organ would. So people might have had strokes, or people might have had small TIAs, so transient ischemic attacks. Or it might just be that they are someone who's had a long history of hypertension, diabetes, high cholesterol, so vascular risk factors essentially that would over a period of time clog up the blood vessels that supply to the brain, and the brain will slow down, and that comes across as dementia. So forgetfulness may not necessarily be a symptom, but because they're functioning very slow, they might be a bit repetitive, or they might struggle with their activities of daily living. They'll take a long time to get things done. So that might be how a vascular form of dementia may present over a course of time. Sometimes you might get a combination of vascular or Alzheimer's dementia, and it goes by the term mixed dementia, not really restricted to Alzheimer's plus vascular, but it's just to say that some people have vascular risk factors, have had vascular events, and they also have a slowly progressing dementia alongside that. People would have come across the term Parkinson's disease-related dementia or Lewy body type of dementia. Essentially, it's a particular condition where parts of the brain are deficit in a particular neurochemical compound called dopamine, which when it involves the movement part of the brain, they might become a bit tremulous, they might feel a bit rigid, shaking, difficulty in walking, and then they also could have symptoms of dementia alongside that. So some of the symptoms as per forget, but it will start off more as a movement disorder. So that might get called as Parkinson's disease-related dementia. On the other hand, people might start with confusion, sometimes seeing things as well, like having visual hallucinations. And then they may go on to have Parkinson's symptoms like tremor or rigidity, and that will get called as Lewy body type of dementia. It's very important to know about this, because last time we talked about delirium and how people with delirium could present with acute confusion and having hallucinations. So the picture would be very similar. So we need to be a bit careful in terms of diagnosing Lewy body type of dementia. And finally, there's an entity called as frontotemporal dementia, or frontal dementias, where it's the front of the brain that's affected. And as we know, front of the brain is very important for us to think, to emotionally regulate ourselves, to be socially appropriate in terms of our behavior. And so when frontotemporal dementia happens, which is uncommon compared to an Alzheimer's type of dementia, for example, but when it happens, people will usually come and say to me, oh, well, my husband or my wife or my father or mother, they are not the same person anymore. The behavior is very different. Maybe they were very extrovert and then now they become very reclusive, or they were reclusive and now they are kind of very disinhibited. So that's the kind of personality change that we are talking about. So they are the main forms of dementia. But as I said at the very beginning, Alzheimer's dementia is the most common type of dementia. About 60 to 65% of the population who have dementia will be presenting with an Alzheimer's type.
Thank you, Dr. Raja. I think you've made that really clear for all of us. And just to say, viewers, sorry, I think my computer keeps pinging with messages. I do apologise, but if I try and turn it off now, I think I might crash this whole Facebook Live, so I don't want to do that. I think you made it really clear about some of those main types, and I really liked your description about the difference between Parkinson's disease and Lewy body dementia. And this is where a memory clinic can come in, can't it? Is it delirium? Is it dementia? What type of dementia? And there are so many other types of dementia that we don't have time to cover in this session, but that's what a memory clinic is for. And just to say, Chris has put a comment in the chat to say that he goes to a memory clinic and he finds it's just really good support with all aspects of dementia, and he wanted to say as well, the staff are amazing. So I think, you know, it does give you the opportunity to look at those things. But just picking up on, there are some other types of dementia as well. There's also another comment that's been put in that says that when this person says when his mother died, his father started to drink, and regrettably they just assumed that his memory changes and various different cognitive aspects were just part of his aging, but didn't realize it could be a dementia that was related to alcohol consumption.
Yes, so alcohol is a very significant factor in terms of regulating our mood as well as our memory. So excess alcohol will have impact on our mood as well as our cognitive functioning. Sometimes alcohol makes a hidden Alzheimer's form of dementia very strikingly apparent. So it could unmask some of that. It could also lead to a lot of vascular events, which will then predispose to a vascular form of dementia. But over a period of time, when people have been using alcohol in a more dependent pattern, then it's their long-term memory that will get impaired. So memory for example, personal life events will be lost, and they will start replacing those with falsified memories, and that becomes very difficult. So those are the various ways in which alcohol can be related to dementia, or alcohol can cause dementia by itself. And I think that is where it's very important to have the right degree of access and support through memory clinic or memory service, because it's always important to recognize that the journey is not just for the individual with dementia, but the carer too, to understand the symptoms, to be involved in the in support, and also feel that they are being supported. And I'm very glad that there was a very positive experience of someone having encountered memory clinic.
Yeah, okay, thank you. And so I'm wondering if, going on to those memory clinics, and clearly Chris has had great support from theirs, I wonder if we could just talk about, well, what happens at a memory clinic, because sometimes people think it's a one-stop shop, you go and but it's often a series of events that take place, isn't it?
Yeah, I would see that as a series of appointments that happen with people who are very specialized in doing various things, starting with the very first thing being getting a good history about what is actually happening in someone's life, and how has things changed over the last 6 months to a year. What is happening in terms of their physical health? What are the problems that they face in terms of their current life circumstance, and how is that affecting their activities of daily living? So nothing is a substitute for taking a very good history. And we have to remember that dementia is a clinical diagnosis. So that bit of history taking will be the very first appointment that someone has. As part of that history taking, they will also have some form of cognitive assessment being completed. They could be very brief, they could be very extensive, depending on at what point of time people are presenting with dementia-like symptoms. And we will also have to recognize that sometimes the individual with dementia may not be able to participate in these tests as well as they could. And that itself says how severe the symptoms are. So there will be an appointment for history taking plus some form of cognitive assessment. And then that will lead to a series of investigations, starting with blood investigations and general review of physical health, because there are things like hormonal imbalances, for example, having low thyroid function, or vitamin deficiencies like having deficiency of vitamin B. All of those could lead to symptoms that will present like a dementia, but they are very treatable. You correct the thyroid level, the brain starts to function very well. You get the vitamin B to a normal level, the brain starts to function very well. And these people should not be mislabeled as dementia, because it's a life-changing condition and comes with a lot of negative connotations attached to it. So that's why blood tests are very important to be done. And they're mainly done by the GP, either at the point of referral or once a request has been made by a specialist. Once the blood tests are completed, then there will be a need to look into whether the person needs a brain scan, and if so, what type of brain scan is needed. We need to remember that there are certain conditions that will make it difficult to offer brain scans. For example, for MRI, there are metal objects, and we need to be very cautious in terms of putting someone through an MRI. Equally, we also want to make sure that it's not really traumatizing for the individual with dementia, because they have to remain still, and any movement will lead to possibility of a misdiagnosis. So all of those things, other than just purely looking at diagnosis, will have to be considered when a particular form of scan is being requested. The scan is there to try and maximize on what has already been established through clinical history taking, the cognitive test that someone would have completed, and the blood tests. As part of the assessment, people will also be seeing sometimes an occupational therapist or a physiotherapist or a SALT specialist, depending on what kind of problems that they are having, because each of those problems will have to be looked to see what could we do to make things better, irrespective of what the diagnosis is. What can we put into place to make the person functioning better, feeling physically better, being more cognitively orientated? So all of that will mean that there may be a combination of various other specialists, like a SALT specialist or an OT or a physio, providing the assessment as well. That's not to say that all of these assessments have to be done. It will depend on what the actual problem is before going down this route. Eventually, all of these things will be put together by a psychiatrist or a neurologist or a geriatrician, whoever practices in memory clinic as a specialist in that particular memory clinic, to then come to a diagnostic conclusion to say whether we are looking at dementia or not. So essentially, there are a sequence of appointments with specialists looking at various aspects of brain function, various problems that the brain is facing, and the consequence on activities of daily living, before arriving at a diagnostic appointment to say what is the diagnosis that's leading to the current presentation.
Thank you, Raja. I think the key points I've kind of picked up there is it's a series of events. It's not just a one-stop shop at a memory clinic. It tends to be a series of events that include blood tests, a really detailed case history, and a long discussion with the person with dementia and their carer. Perhaps a scan, and there are different types of scans, and one size certainly doesn't fit all, and sometimes no size fits the person because there may be complicating factors that means that they can't do that. And then you might pull in, and there'll have been some paper-based exercises, some cognitive assessments. And then a clinic may also pull in other what we call allied health professionals, so physiotherapists, occupational therapists, and when you referred to SALT, you were talking about speech and language therapists for people who don't know that sometimes speech and language therapy is shortened to SALT. And those professionals are looking at a strength-based assessment of what the person can do, what they're having difficulties with. And I think from my perspective as a speech and language therapist, certainly another really important aspect of that is not just what can someone do, but actually how do they respond to different types of prompts? Because different types of prompts can give you an idea of some more information to your diagnostic procedure as to what's going on for the person and what the difficulty is. So you might have, and I see Helen did ask what's a SALT specialist is, you may have a physio, an occupational therapist, a speech and language therapist, you might already have had a clinical psychologist. And then ultimately it comes back to your expertise then, who pulls all that information together and is able to get to the point of a diagnosis. I'm wondering what your thoughts are on, sometimes I think when I was in memory clinics, they often said one of the best criteria, or one of the really strong criteria, which often doesn't help carers, is time to see how things evolve. So sometimes we can't just give a straight answer, but need to bring someone back a few months later to see how things are changing. Would you agree with that?
There will be instances like that, which is very important. And it's not time in the sense of time doing nothing or time just waiting for things to deteriorate. It is time to perceive, to see how much of adaptation brain can do over a period of time to overcome some of the challenges that someone might be having. Or it may be that some of the things that have been picked up, like say, for example, people might have a vitamin deficiency alongside an emerging dementia, and it's trying to see how much of this could be rectified and what is actually left with at a particular point in time.
And I think that's a perfect example, Raja, because there's a comment here from Gail who says, thank you, Gail. Her husband has alcohol-related brain changes, and he's got 3 months to reduce to 14 units a week and then a follow-up. So that's another example, isn't it? That there's an active time period in which to see what changes.
Yeah. Or equally, that someone could be quite depressed for whatever life circumstance that they are in. And it may be that managing the mood symptoms might actually make things much better in terms of their cognitive functioning. So the time is there to try and rule out things that could be masking as a dementia. Or it could be for the fact that because we need to be looking to make sure we can treat things in an effective way and then see what is a residual problem. So it is a very useful time, and most importantly, I think it's important to understand that carers should feel supported during this process of waiting, and that's why one of the assessments that will happen when, or should happen when they see a specialist, is having access to carers assessment itself. Because if the carers are being supported in what they're doing, then the outcomes are always better for the individual with dementia, and it reduces carer stress and burnout. So I think that waiting period is a period to understand about the illness, but equally it's also a time to understand how we can support the individual and the carer through the process of diagnosis.
And again, a really important point. So, as you know, we at Dementia Carers Count, we support the wellbeing of family carers, supporting someone regardless of whether that person has a diagnosis of dementia or not. And there is an emotional toll in caring, and that can have a huge impact on wellbeing. But your emotional health and well-being can also be impacted by the worry and the anxiety of going through the memory assessment process. It's not just the person who's got the symptoms that will be having an immense amount of worry and anxiety, perhaps, about what's happening, but also the carers will as well. And we do various live online events, and we have various pieces of information in the website that I really hope will help people out. I'm going to keep us on this topic, but I just want to very quickly address one comment that's come into the chat. And that's regarding someone, Susan, saying that her mum in the evening is getting evening agitation. Susan, please get in touch with us. We also do have lots of information on our website regarding evening agitation, and we run a live online event about that. So I'm not wanting to ignore your comment there, but we won't address it within this session if that's okay with you, but do get in touch with us or have a look on the website. So I'm going to pick up a comment by Samantha. We haven't got long to go, but I want to cover this one if that's okay. Samantha says that she's really thankful that she took her mum to the GP when she did. She actually lives 80 miles away from her mother. So, you know, there are lots of carers out there who really are family unpaid carers, but don't necessarily live next door or within even the same town. She'd only seen her 4 or 5 times in I saw her every 4 or 5 months, and it was her neighbours that alerted her to the problem. So it can be useful to use the wider network of family to help in supporting with this as well, can't it?
Yeah, absolutely. I think a lot of elderly people do interact quite a lot with the neighbors, who are very good at picking up subtle changes. They might meet them for lunch groups or group activities of any kind, going on walks. So that's why when all of us do history taking, we do talk about what kind of activities do you do during the day, and then ask about people who are involved, who we would be happy to talk to with the consent of the individual presenting to us with symptoms of dementia. And And I think it's important to have that network as well, going through the process of diagnosis and post-diagnosis. It's important to have that sense of familiarity about people with dementia, people that they know of, people that they trust, environment that they actually have relish living in. So I think it's important to take all of those into account. And I think one thing that we found was during COVID, because we were running virtual clinics, it was interesting that people who had sons and daughters live in the States or Australia join in virtually, and it made it more meaningful for them to be part of the assessment and conversation. I think it would be very useful to, as a family carer, to at least get to speak to someone by phone or by any form to discuss the symptoms and the concerns that you have, because it's we do need that degree of good history taking and understanding to know the person with who's presenting with symptoms of dementia. It's more knowing the person that's going to answer some of the problems going forward, rather than just a diagnosis or the treatment forms, which I'm sure we'll discuss in the third session. But I think one of the important things would be knowing the person, and there is no replacement for all the information that we could get from family and friends.
Wouldn't it be great to have those hybrid clinics where perhaps some people in the room, and we've got the technology now, haven't we? Really, we've got used to it with the pandemic, to perhaps have somebody on a phone who's in the room giving some information as well. That'd be a fantastic way forward, wouldn't it?
Absolutely.
I'm going to do a little flag here. We talked about there's lots of support in the website in terms of that umbrella term that you talked about around dementia, and some of the main types around it, around resilience and well-being. And Fiona has just said she's done several of Dementia Carers Count courses and recommend them. She says they're marvellous. Thank you, Fiona. Had to read that one out. So I think you touched just now about where we're going to go next with this. We've said to viewers that this is the second of 3 Facebook Lives. And in the first one, we talked about some of the main symptoms, and you kindly went over today the FORGET acronym again. And then we talked about some of the main types of dementia, knowing that there are lots of other types of dementia out there. So if anybody's viewing and we didn't mention the type of dementia that you're supporting someone with, by all means get in touch with us, and we can give you some more information and signpost you to information as and when you need to. When you were talking about those types of dementia, you talked about vascular being quite different because it was around other physical changes in the body, and some of it contributed by lifestyle changes. And then just now you said next week we're going to look at, once you've got point to the diagnosis, we look at treatment options. And I think, bearing in mind what you said about vascular dementia, am I right, next time we're going to look at those sorts of management of symptoms through lifestyle changes and perhaps medications? Am I correct?
Yes, absolutely. So we have to remember that medication is just one ingredient of a whole raft of measures that we could provide to support people with dementia and the carers who look after someone with dementia. And some of them will be focusing on lifestyle measures, including physical activities, mental activities, the kind of social stimulation that people with dementia will need, different forms of specialist therapists that could be very helpful to people with dementia, and also what kind of carer support that would be making it more meaningful for family carers who look after their loved ones with dementia. So we'll be touching on all of those kind of interventions to try and support people with dementia.
And we're going to do that at the beginning of March. We're yet to decide on the date where both of our diaries work for that, but it will certainly be at the very beginning of March that we will do that sort of carer clinic with you, if you like, again, Dr. Raj, and I'm really looking forward to doing that. So as we come to the end now, are there any sort of key final messages that you would like to end the session with? Anything really important you feel carers should know?
I think it's important for the carers to have a conversation with their family member who they think has possible symptoms of dementia, and take it to the GP, and then understand that there's going to be a sequence of appointments over a period of time before things become very crystallized. And during that course where they face any degree of challenge or difficulty, then they should be asking for a carer's assessment and appropriate carer support, including contacting us. And I am going to flag this for you, Sue, that I've heard very good feedback from the 0800 free number that we run. So I would also recommend people to look into using that.
Absolutely. Thank you, Raja. And we can put all that information in the chat box for people here. If I've missed any comments that have come up, I do apologise. Sometimes it's difficult to make sure I'm listening to Raja, because it's really important I do so, but also really important that I see your messages. If I have missed any, then we will go back and somebody will come back to you. And as I say, with the one around evening agitation, please do have a look on our website, and there are some resources there for you. Thank you once again, Raja, and I'm really looking forward to our next conversation on this topic at the beginning of March.
Thanks, Sue. Thank you very much.